and then I will move on to Professor Fragasso, who will hopefully now tell us much more about medical therapy.
Thank you, Rasha. Professor Alame has been showing us a lot of points. I mean, a lot of studies they have been making in their institution, and also gave us brilliant outcome on the future research. We are waiting to see these results. We're very happy to know this about this new study. So I will start my presentation by just saying that when we treat chronic disease, we have a lot of problems, because yes, I mean, we do angioplasty, sometimes we do not resolve the problem. We still have to give medical therapy because of persisting angina. And angina, as already been shown by Professor Alame, is still a problem despite often successful revascularization. I mean, there are several studies showing this. The Courage trial was the first. So we know that after 5 years of successful revascularization, you might still have angina. And also we know that angina per se as a sort of risk factors for development of further events. We know from the REACH registry that 3 out of 20 patients with established coronary artery disease will have a major event or will have an hospitalization within 1 year, so not a real benign disease. And in fact, if you look at the Clarify registry, patients with prior MI or no MI, whether they have angina or not, they will develop some kind of cardiovascular events with time, which is approximately between 7 and 15% at 5 years. So this ongoing angina and or ischemia is associated with a worse prognosis. So why do we have a worse prognosis? We're talking about angina, but angina is just a symptom. We know that we might have persisting inducible myocardial ischemia despite successful revascularization in many patients. This is a small study, but clearly shows that stress testing after successful revascularization continue to be positive at 1 month, 6 months, and 12 months. So in about 30% of the cases. And this is very important because these patients, despite revascularization, are still having angina. And why do they have angina or ischemia? Probably because also microvascular disease is at work. There are several studies showing this. I mean, in this small study, they were in a contemporary multi-center prospectively enrolled population of patients presenting with stable angina. Around 71% of these patients had evidence of coronary microvascular dysfunction. And microvascular dysfunction is represented here. You can see this is an intramural arteriole in a patient with chronic ischemic heart disease. You can see that there is diffuse narrowing of the vessel, and this actually resembles plaque formation in the epicardial macrovascular coronary disease. So this is the problem. Atherosclerosis is a systemic disease, and therefore also the microcirculation can be affected and can be at work by provoking damage. And we know, in fact, that in different subsets of patients, microvascular disease is associated to a greater extent compared to patients without any microvascular disease with development of heart failure, because this microvascular disease will eventually work and eventually provoke events and heart failure. So other problems when we treat chronic coronary disease is silent myocardial ischemia. We know that about 25 and between 25 and 45% of patients with chronic coronary disease will have myocardial ischemia during daily life, and around up to 75% of these episodes will be silent. So when we talk about anti-anginal therapy, you have to think that these patients, many of them, in several occasions, they will develop silent myocardial ischemia. So angina, to treat patients just by guiding the therapy relative to the presence or not of angina is not a good point. And finally, also, adherence to therapy is another problem. several factors, of course, affect the medication adherence of patients. I'm not going to bother you with all these factors, but certainly you are all expert physicians, and you know that drug side effects, real or perceived, are a big problem. Patients are on polytherapy, and therefore they can actually have a lot of side effects of drugs, beta blockers, calcium channel blockers, long-acting nitrates, which are the mainstay of the treatment of chronic coronary disease, are hampered by several adverse effects, especially when these drugs are given in combination. So we have to keep in mind the medication adherence of our patients. And in fact, medication adherence in Asia is this is the non-adherence to cardiovascular medication use in Asia goes up to 70% of patients not being adherent to therapy, and in Western Europe is around 50%. So this is a problem which is also affecting probably prognosis. And finally, elderly. We are treating a lot of old people. We know that after the age of 65, we know this from the Framingham Heart study, from the cardiovascular health study, that after 65 years old, I mean, one out of 3 subjects will have some kind of coronary disease. So we have to keep in mind that elderly patients are also frail, and therefore medical therapy should be adapted to the single subject. So which tools do we have to treat coronary disease? Well, you know, if you look at the mechanistic targets of anti-ischemic drugs, we can generally say that we can try to improve supply, for example, by generally speaking, giving vasodilators, or we can reduce oxygen demand by giving beta blockers, calcium channel blockers, or ivabradine. But then we might still develop ischemia, as we have been seeing today. And when you have ischemia, you have a lot of metabolic abnormalities which actually are not targeted by this treatment. So you have ischemia, you might prevent partial ischemia, but when you have ischemia, you have metabolic adaptation which is not targeted by the present therapy. And we know that we can treat also the metabolic abnormalities provoked by ischemia by different metabolic approaches. Well, look, let's see what the European Society of Cardiology tell us about the medical therapy of stable coronary disease. Well, they talk about patients with angina again, so they're not talking about ischemia. But anyway, as an anti-anginal treatment, they indicate short-acting nitrates, beta blockers, or calcium channel blockers alone or in combination, depending on whether the patients respond effectively to one of 2 drugs. But then you have some other drugs, for example, nicorandil, ranolazine, ivabradine, or timidazine, which actually are indicated as class 2. I mean, the others were class 1. These are class 2. Why? We do not have any specific trials showing that the previous drugs, beta blockers, calcium channel blockers, nitrates actually clearly improve prognosis. But then we have a difference of indication in terms of class of indication, where some drugs are second class. Let's see whether we can try to change this attitude. So let's see at what happens when we have when we analyze metabolism in the normal heart. We know that the normal heart utilizes 60% free fatty acids for the formation of ATP through beta oxidation, while glucose represents around 40% of the substrate utilized again for the formation of ATP. We also know that this approach, the glucose oxidation approach, has an ATP-O2 ratio around 6.3, while the utilization of free fatty acids is less efficient from a metabolic point of view. You can see that the ATP-O2 ratio is about 5.6. When you have increased demand, then glucose represents the major part of the substrates utilized by the heart, and free fatty acids represent 30%. But then when you have metabolic dysfunctions, for example, in diabetes, in ischemic heart disease, in the failing heart, we have impaired capacity for glucose uptake and glycolysis. We have a decrease in carbohydrate oxidation and increased free fatty acid oxidation. So pyruvate dehydrogenase complex is not working anymore. Glucose goes into production of cell acidosis and lactate, and then most of the ATP production comes from free fatty acids oxidation, which, as I said before, is not very efficient from a metabolic point of view. So what can we do to overcome this problem? Well, we can try to make the entrance of glucose easier into the cell by, for example, giving insulin and potassium. We can try to restore the pyruvate dehydrogenase complex by giving dichloroacetate, which unfortunately is a very toxic compound, so it's not easy to administer in the clinical setting. We can try to reduce the entrance of free fatty acids into the mitochondrium by blocking the carnitine palmitoyl transferase 1 and 2 shuttles, and perexilin, atomoxil, amiodarone probably can try to stop these shuttles, but then also we can try to block beta oxidation exactly inside the mitochondrium by drugs such as trimethazidine. And in fact, trimethazidine has been shown to actually partially block the long-chain 3-ketoacyl coenzyme A-thiolase enzyme, and by partially blocking beta oxidation at this level, we can restore pyruvate dehydrogenase complex and formation of ATP from glucose, which, as I said before, is a more efficient metabolic pathway and it actually permits a gain of 20% of metabolic efficiency in the production of ATP. So let's see whether we have any evidence of this kind of therapeutic approach in patients with angina pectoris and coronary disease. I mean, there are several studies showing that trimethazidine can be effective versus placebo, versus beta blockers, versus nitrate, and also it has been assessed in combination with calcium channel blocker and beta blocker. I'm just showing to you some slides relatively to these studies. In this study, trimethazidine was compared to placebo. You can see that when patients were on trimethazidine, exercise duration was longer compared to placebo. The time to 1 millimeter ST depression also was longer, and the total workload was better with trimethazidine, and the rate pressure product was higher on trimethazidine. So that means that we're able to exercise longer with a greater rate pressure product and, of course, less probably ischemia. And this was a study, this is an old study. In fact, this was a study comparing trimethazidine versus propranolol, which is not a drug anymore used in the clinical setting of coronary disease, but anyway, it's still an effective beta blocker. And you can see that when trimethazidine was given, the number of angina attacks per week was similarly reduced as for propranolol, and also the consumption of nitroglycerin tablets per week was significantly reduced with trimethazidine and propranolol, and there were no differences between the two compounds. And this was the rate pressure product, no changes with trimethazidine, while when patients were on propranolol, the rate pressure product was already less at rest and at peak exercise also. So this is the exact mechanism of function of beta blockers. You reduce oxygen consumption, and while trimethazidine does not do anything, because as you can see, rate pressure product did not change. So despite a similar rate pressure product, the ischemia was probably less. So this is the last study showing that trimethazidine compared to isosorbide dinitrate. This was the number of angina attack per weeks. You can see that nitrates were reducing angina attacks per week similarly to trimethazidine, and actually trimethazidine was reducing the consumption of nitrate tablets compared to nitrate long-term nitrate administration. And then finally, a combination of trimethazidine on top of therapy with metoprolol. You can see that after 12 weeks of therapy, patients on metoprolol plus trimethazidine compared to metoprolol alone had a greater time to 1 millimeter ST segment depression, a greater time to the onset of angina, and number of angina attacks per week significantly reduced, as well as the number of nitrate tablets used. So on top of metoprolol, trimethazidine added an additional value. And this was a similar study, this time comparing diltiazem and diltiazem plus placebo, and diltiazem and diltiazem plus trimethazidine. Again, when trimethazidine was added to diltiazem, the time to 1 millimeter ST segment depression was higher. So patients were able to stand greater amount of ischemia. So in daily practice, trimethazidine, whatever the conventional treatment, improves clinical status with an excellent tolerance. But then the question was, what do we really do in terms of really reducing ischemia? Because we were talking about angina, but what we want to observe is whether we, with a specific therapies, we can actually reduce the ischemic burden in these patients. Well, in this study, we evaluated left ventricular function during dobutamine stress echocardiography in patients with chronic coronary disease undergoing dobutamine stress echocardiography. We randomized patients to trimethazidine or placebo for 15 days, then tested here at the 15th day, then crossed over to the other treatment arm for additional 15 days, and then tested here again. You can see that when patients were on trimethazidine compared to placebo, plus additional, hemodynamic drug, because these patients were having trimethazidine or placebo on top of medical therapy. You can see that when patients were on trimethazidine, the dobutamine dose we were able to administer was higher, so we were able to stress our patients to a greater extent, and despite a greater stress, the left ventricular wall motion score index was less with trimethazidine compared to placebo. So more stress, more probably ischemia, but less left ventricular involvement. But the very interesting thing at this time was that the wall motion score index was already better at rest in these patients. So that meant to us that probably during those days, patients were having less ischemic involvement of the left ventricular wall. So that meant that probably this approach could be effective. And in fact, we know that in patients with stable coronary disease, the development of FPEF and ejection fraction with reduced ejection, heart failure with reduced ejection fraction is increasing with time, and after about 10 years of stable coronary disease, about 15% of patients will have developed some kind of heart failure. So this is a very important factor. Those patients having stable, what we consider stable coronary disease, will actually have some kind of the left ventricular deterioration with time. And this has been also shown by the Clarify registry, where the combined endpoint of cardiovascular death, heart failure, hospitalization, or new symptoms of heart failure at 5 years is about present in about 30% of the patients. So this is an important factor that we should try to prevent. So the next question was, well, does this metabolic approach improve left ventricular function in patients with left ventricular dysfunction or different etiologies? Well, we took 55 patients with heart failure, randomly allocated in an open label fashion to either conventional therapy plus trimethazidine or conventional therapy alone, and we followed them up for about 13 months. And you can see that when patients were on trimethazidine, ejection fraction was significantly higher compared to baseline, while in patients on conventional therapy alone, ejection fraction did not increase. I would say that rather decreased, which is actually representing the natural history of the disease. And when we divided these patients, according to whether their heart failure was due to ischemic heart disease or non-ischemic heart disease, you can see that the increment of ejection fraction was exactly the same. There were no differences. Trimethazidine improved ejection fraction versus conventional therapy alone, both in the post-ischemic and non-ischemic group. So we were very happy with this, but then the question was, what do we really do when we do this, when we prescribe these drugs in patients with ischemic or non-ischemic left ventricular dysfunction? Do we really improve cellular energetic reserve? Well, we did this study, a small study, but very significant. 12 patients with heart failure, of whom 6 were having post-ischemic heart failure and ejection fraction less than 45% on full guided conventional therapy, full guideline-directed medical therapy. And this was a double-blind, placebo-controlled crossover study. Patients were randomized for 90 days to either trimethazidine or placebo. And at the end of each period, we measured left ventricular function by echocardiography. And we had this good tool, which is the magnetic resonance imaging spectroscopy, which actually permits us to measure the PCR ATP ratio, phosphocreatine adenosine triphosphate ratio. We know that these two compounds are in equilibrium, and phosphocreatine represents a cellular energetic reserve, which is employed in order to maintain ATP levels, which are very important for the contractile work of the heart. And this is also called myocardial energy balance index. We know that in normal subjects, this ratio is between 1.6 and 1.8, but we also know that it is significantly reduced in different cardiac conditions, including ischemic heart disease and heart failure. Well, in this study, we again were able to demonstrate that after 90 days of treatment, trimethazidine on top of guideline-directed medical therapy was able to significantly improve ejection fraction. But the very interesting finding was that the PCR-ATP ratio, which again represents the cellular metabolic reserve of the myocardium, when patients were on trimethazidine, we were able to restore normal PCR-ATP ratio compared to placebo and to a level which was not dissimilar from what we observe in controls. So that means that we were able to improve the cellular energetic reserve of our myocardium by 33% by adding trimethazidine to conventional therapy alone. So just to finish my presentation, when we talk about myocardial ischemia, and as Professor Alamea has already said before, we do not have to think about coronary stenosis because there are several factors contributing to the final development of myocardial ischemia. Then, of course, we can treat coronary stenosis, we can treat platelets and coagulation by antiplatelet statins, we can treat maybe in the future systemic and inflammatory and autoimmune disease. We can treat specific primary metabolic abnormalities. We can treat myocardial bridge, vascular spasm, coronary microvascular dysfunction. We have several means for treating these factors, but still, as we said before, we might have development of myocardial ischemia, and none of these approaches are targeting the core of the problem, which is myocardial ischemia. We think that we should probably manage the effects of ischemia by giving some kind of metabolic treatment. And trimethazidine is one of these approaches, which in several studies has been shown to be effective in reducing the metabolic effects of ischemia. And these authors, which actually made the pictures I showed you before, just concluded that there is no evidence to support the use of first and second line treatments for the management of angina. We should try to individualize our treatment for patients, and we have to think about elderly people, a lot of side effects, and also the fact that these patients keep on having myocardial ischemia, inducible or not inducible, but still that ischemia will eventually end up in left ventricular dysfunction and heart failure, which is the problem of the future. So metabolic therapy in angina, why not the first line or together with first line drugs? It has been shown to improve left ventricular function, to reduce ischemia, to improve global metabolism, and has not any hemodynamic effects. So that means that it's very well tolerated. So I keep you with these slides. Many thanks for your attention, and I'm eager to know your questions if you have any. Thank you.